Next up is depressive disorders. Major depressive disorder is one of the main ones that we will find and we will see in practice. But know that the category of disorders, or the classification, also includes disruptive mood dysregulation disorder, which is a real kind of anger and crabbiness and lashing out. Occurs primarily in males and may be seen in youth. So that's another one. Persistent depressive disorder, premenstrual dysphoric disorder. So that may be occurring in our young women, and then substance or medication induced depression. Okay, so in looking at the symptoms, there needs to be 5 or more of the following, and it would need to be for a certain amount of time. Depressed mood, loss of interest or pleasure, which we noted before, unintended and significant weight fluctuations, either up or down, insomnia or hypersomnia, also psychomotor agitation or retardation. So you're either very motorically agitated or you don't want to move at all. Fatigue, feelings of worthlessness, difficulty with thinking and focusing, and potentially recurrent thoughts of death. So those are the features of major depressive disorder. They need to be present for a certain period of time with a certain intensity and a certain number of them, in this case 5. With regard to what OT can do, again, cognitive behavioral therapy is within our scope of practice. Also, dialectical behavioral therapy, which combines psychotherapy with psychosocial skills training. So we'll be delving into that in upcoming sessions as well. Also, again, psychoeducation, peer support programs, supported employment, establishing meaningful routines, and helping the individual to manage medication. So you see the same set of treatment strategies as with bipolar disorder. Next up are our anxiety disorders. So anxiety, we're going to talk about generalized anxiety disorder and social anxiety disorder. General anxiety disorder is characterized by excessive anxiety and worry a majority of days for 6 months and about a variety of things. It's very difficult to control the worry, and the person has 3 or more of the following symptoms: restlessness, easily fatigued, difficulty concentrating. They may be irritable, they may have muscle tension, and they may have sleep disturbances. With social anxiety disorder, the DSM used to call this social phobia, and now it has been renamed in the DSM-5. It is more than just a person being shy or introverted, and it can be very disabling. So the diagnosis requires that a person's fear of social situations or anxiety of social situations be really out of proportion with the actual situation. There's a fear of showing anxiety symptoms and being embarrassed or humiliated, so that all eyes are on me kind of thing. And to be diagnosed, the symptoms must last for 6 months or longer, and the individual must experience fear of one or more social or performance situations in which they either are meeting unfamiliar people or they're possibly exposed to scrutiny from others. Also, the exposure to the feared situation provokes anxiety, which may be situationally bound, or it may predispose the person to a panic attack. So the panic attack then takes place in the body with shortness of breath and elevated heart rate and pulse. A number of sympathetic nervous system symptoms take place. So The panic attack is definitely associated with social anxiety disorder. Also, the person experiences significant distress and impairment that interferes with their daily functioning. So that's a really important part. That's it for that one. There's some information in the slide deck, and once again, please download the slide deck so that you can see the information in the presenter notes. That's my little note to you in this slide deck, so that you can read about other aspects of these disorders. All right. Application to OT. Again, cognitive behavioral therapy can be effective. Also, slowly establishing peer support groups, so it not only encourages the individual to engage socially in a supported and safe manner, but it also does that quite gradually. And then an incremental introduction of social stressors in a protected environment. So either the peer support group environment or another environment where the situation, just to begin with, really warrants supportive folks who are in that person's court already. Next up are trauma and stressor-related disorders. One of the trauma-related disorders that most of us are familiar with is post-traumatic stress disorder, or PTSD. The definition of it is exposure to actual or threatened death, serious injury, or sexual violence. The presence of at least one of the following is necessary: that in reaction to this actual or threatened stressor, the person has recurrent or intrusive distressing memories or dreams. They may have flashbacks. They may experience intense or prolonged psychological distress from triggers. So, for example, if somebody sees someone that looks like a sexual predator and the person that was their perpetrator, they may experience a very long-lasting psychological distress just from being triggered. And so that's what a trigger is about. And then there's a physiological reaction to triggers. So that may be a panic attack. It may be a physiological withdrawal. It may be stomach issues and digestive issues, all due to a sympathetic nervous system response. The exposure, just as a note, can either be direct experience of any of the events. It can also be, PTSD can be triggered through witnessing violence, through learning that it occurred to a close family member or friend, or to experience repeated or extreme exposure to the aversive details of the traumatic event. So that can occur to police officers, firefighters, and other first responders. So it's not actually happening to them, but they're exposed to it in such a relentless way that too can trigger PTSD. There's also a persistent avoidance of triggers. So the person is trying to avoid getting triggered, which, as you can imagine, makes their world increasingly small and controlled, and would interfere with their daily participation in activities. There can be negative alterations in cognition or mood, marked alterations in arousal and reactivity. So your firing point tends to be very low, and you're easily startled, you're easily upset, you're easily moved into reactivity and out of a self-regulatory state. And these symptoms need to last for at least 1 month. There's a lot more symptoms in your presenter notes, but for our sake today, that's what I'm going to go into. Please review those so that you get a really good idea of what this disorder looks like. Adjustment disorder is related to are trauma-induced disorders, and it is the development of an emotional or behavioral symptom in response to a stressor. So it's within 3 months of the onset of the stressor, and there needs to be it becomes clinically significant because there's distress that's out of proportion with the event or the result, and it results in a significant impairment in functioning. So the person is not coping well with a stressful event or a set of stressors. And what we see with COVID and with just a lot of us who have been going through the pandemic is that this adjustment disorder is very, very prevalent. We're seeing a lot of folks who are experiencing the pandemic and not being able to cope well. What can OT do? Well, we can help with cognitive behavioral therapy, dialectical behavioral therapy, introduce mindfulness and other stress reduction techniques, sensory techniques to help calm the nervous system and regain a state of self-regulation, and help the individual to really focus on healthy routines and habits and role exploration so that they're sitting more comfortably within their daily life, which would then lead to an increase in their ability to function. We're also going to just touch on complex trauma, and this is not a diagnosis that's in the DSM, but it is important because we may encounter folks who have complex trauma. It refers to repeated exposure to traumatic events, typically during childhood, things like abuse or neglect, and it impacts the child's development and attachment style. So the thing about complex trauma is that it's chronic and it's built up over a long period of time. And we see this in kids that have been abused or neglected. We're also seeing it in kids that are asylum seeking or refugees to the U.S. That have been separated from their parents. We see it in kids who have been abandoned and have been in orphanages and not gotten a lot of care or attachment bonding with caregivers. So it behooves us to note this. And the connection to youth is that even though the individual may not be experiencing these events actively anymore, it's kind of like the damage has been done. What we know about attachment is that it happens very early in life, from birth to about 18 months. After that, the sequelae linger even if the child is no longer experiencing the abuse or neglect. The Adverse Childhood Events, or ACEs study, was conducted by Kaiser. You may already be familiar with it. They looked at thousands and thousands, perhaps hundreds of thousands of clients, and they came up with a hypothesis and then some evidence that when kids experience adverse childhood events, which include abuse, neglect, or household dysfunction, so they're divided along those lines, and abuse is either physical, emotional, or sexual. Neglect is either physical or emotional, so either one. And then household dysfunction includes things like a caregiver with mental illness, an incarcerated relative, a mother who was treated violently, so domestic abuse, substance abuse in the home, or divorce, and actually death of a parent is missing from this. So when kids experience any or several of these, so they're not mutually exclusive, they have long-term negative outcomes. And the outcomes are in terms of their physical health, their mental health, their ability to socially interact, and their behavioral health. and it impacts their ability to process and cope with stress. Um, so, uh, so this study was very groundbreaking because it said to kind of the world at large, these things are important. We can very highly correlate some of these events with things like asthma, heart disease, obesity, mental health conditions like depression and anxiety. So we know that when kids experience adverse events or trauma early on, the repercussions keep going, just like when you drop a pebble in a pond and the ripples keep moving out. It's a very interesting area of work. I actually work with a lot of kids who have experienced trauma early on in life, and our OT approach has to do with developing coping strategies, um, not re not re-triggering the individual, and creating healthy habits and routines for our teens. There are a number of videos in the presenter notes that you can view if you want to get more information about this. And our California medical surgeon general is Nadine Burke Harris, and she has done quite a lot of work in San Francisco and surrounding areas on kids who have experienced ACEs and the ramifications of that. She's written books about it. You can also read lectures. I've seen her speak. She's really amazing. So Nadine Burke Harris is another resource for you. All right, moving along. When we are working with anyone who has experienced trauma, whether it's PTSD, adjustment disorder, or ACEs, there's some principles. And OT in the past 10 years, maybe 5 to 10 years, has really dug into and investigated our role in trauma-informed care. And AOTA has some great information about it. So, trauma-informed care principles, and there's many more than these, but this is a high-level overview. Safety is first and foremost. We want to protect that person from triggers and from re-experiencing any of the trauma, physically, emotionally, psychologically. Also, to develop trustworthiness and transparency as a clinician. So we are going to really focus on developing rapport and trust with our client and being very transparent. So what they see is what they get. We're not going to spring anything on them. We're not going to fail to mention anything in their treatment plan. We're going to be very upfront with them in a kind and empathetic way. We also want to encourage the client to get peer support. So knowing that you're not alone with trauma is a very powerful tool to dealing with it. And in fact, with the ACEs and treatment of the ACEs, what we know is that when doctors and other healthcare professionals bring up questions like, have you experienced early trauma? Were you physically abused or neglected as a child? The acknowledgement that happens and the talking about it and taking it out of the closet can be a very powerful tool just to getting the person on the road to being able to recover in some way, shape, or form from some of the issues. It's hard to recover, but it can happen. Collaboration and mutuality with our clients is very important, so we're not going to have a power dynamic with them in as much as is possible. We're going to be on the same level playing field. We want to empower them and give them a voice and choice. So the choice and the voice is, with regard to OT, is in their care plan. We can recommend and suggest, but we're going to really focus on partnering with our clients so that we're not doing to them. We're in mutuality with them and actively seeking ways that we can help empower them in their lives. We also want to be aware that cultural, historical, and gender issue competence and sensitivity is really important. So, some of the trauma can happen and be stored or stigmatized due to any of these factors. So culturally, across cultures, how trauma is dealt with can be of issue. Historical is basically like multi-generational trauma. So with regard to child abuse or sexual abuse, the grandfather or grandmother did it to their children's generation, did it to their children's generation, did it to their children's generation. So we grow up doing what we were taught in some ways. And so breaking that cycle and being aware of that cycle is important. And then in terms of gender issues, what happens to who and how, and really digging into what the specifics that are around gender and gender identity and issues of trauma. Finally, I guess the last thing that we wanna think about is the awareness of insidious trauma. So trauma that kind of goes below the our radar, and also our own need for awareness of our own situations and the self-care that is really involved in doing this work. So it's hard work. It's painful work and can be frightening work, and it's really important and rewarding work at the same time. But we need to care for ourselves, set up very clear and compassionate boundaries, and get support for ourselves.